Okay, a very warm welcome to all of you to today's Primary Spine Provider Collaborative Case Review webinar. This is part two of a very interesting series that we are doing with Dr. Dino Del Mastro. He presented a case to us several weeks ago, which really is arguably one of the most stubborn and sticky cases of low back pain that I personally have ever seen. And we are very much waiting with bated breath to hear the updates from what was given clinically and advice-wise to Dino on the last webinar. But very briefly, we're going to do a couple of things. First, introduction to Dino. So Dino is a graduate of Palmer College Chiropractic from San Jose, California, as well as a certified primary spine practitioner from the University of Pittsburgh. He's been in practice for over 10 years, and he is also he has a Bachelor of Science in Health and Physical Education and Fitness from Slippery Rock University of Pennsylvania. Second, we've got our panel that's going to include Dr. John Ventura, Dr. Marsha Spoto, and Dr. Donald Murphy. So with that, we're going to hand off to Dino. He's going to review he's going to review the case, just for those who may be attending for the first time and haven't watched the recording of the first one. And then he will go on to the updates. During the course of the webinar, feel free to type comments in the chat. If you have any questions or comments, feel free to fire those away in the chat. We have enabled chatting with everyone. And if you want to speak your question or comment verbally, just raise your hand and we will promote you to be able to speak. And we look forward to the participation. So with that, Dino, over to you.
Thank you so much for the intro, David. I really appreciate it. And thank you for the Primary Spine Provider Network for having me. It's not only an honor to be here, but I'm very fortunate to have this panel of some of the greatest minds in spine care that are going to help me with a case that has really become near and dear to me. I've gotten to be quite close with this patient. And before having the opportunity to speak with everyone here, I was really kind of scratching my head about what to do with this patient. And I think we're making some headway, but I'm really excited to update everybody on some of the latest findings. And I'm curious what your thoughts and recommendations are. So once again, as David mentioned, this is the update. So about a month ago, we did a basic kind of touchdown on what's going on. I took some recommendations since then, and I've made some changes. So should be interesting to tell you guys all. But whoever did not see the previous recording, I'm going to give you a quick rundown. So this was from about a month ago. Now, a couple of updates also from the patient, because I also shared a lot of this information with him, and he had a couple small changes that he wanted to make in the narrative also. So my patient's name is Jim, and Jim, his first comment was, I was born in 1963, which makes me 61 this year, not 63. So he's 61, not 63 yet. So Jim is that quick kind of idea about what he looks like. He's 5'8". He's 165 pounds, and he has had low back pain. He points to it very specifically around L3, L4 on the left, and says that the pain can run across his back, but like a band, but it's sharp at that L3, L4, L5, that whole area on the left. Onset mechanism. Now, here's the kicker, and here's the selling point for this whole case of why I need some help on it. This pain is constant low back pain since around 2002. It's 2024. It's a lot of time to be in pain. He's been treated with chiropractic manipulation, physical therapy, cortisone injection, epidural steroid injection, gabapentin. He's consulted a number of primary care physicians, even several orthopedic surgeons, doctors of chiropractic, doctors of physical therapy. More or less, the biggest rundown on this is that when we were working with him on a numeric pain scale, he said he's at a constant, like his baseline is a 7. His start back score gives him relatively low risk. And more or less the patient just says he's quite an active guy. You'll see I have some pictures that we might end up sharing and some videos, but he said he walks and hikes about 2 miles a day. Sometimes on weekends, he'll hike 8 miles. So he's a fit guy. He's in great shape. He lives a very active lifestyle, and his favorite hobby is fly fishing. Now he says that he's tried taking time off from all these activities, and he's tried just doing things to recover. And he said he might get some temporary relief, but it always seems to come back. Additionally, he did want me to mention, okay, update on the ibuprofen. Okay. In the previous conversation, we said I take 600 milligrams of ibuprofen every morning. Sometimes I take another one before bed because of what I did that day, because if what I did that day caused it to be worse. For the last 3 weeks, only if the pain is severe and not the AM regardless. So more or less, he's 600 milligrams of ibuprofen. We did see some x-rays, which perhaps once we switch back to David to kind of repitch all this, I'll have him show a couple of the reports from the previous conversation, and then I can tell you the updates on it. So when I came to the Primary Spine Provider Network to present this case previously, and again, I must emphasize he doesn't have no real radiating pain. Again, it's somewhat localized. Deep tendon reflexes are all normal. No motor weakness. Sensation is all normal down bilateral legs. So we can kind of go into the updates. So since the last time that we worked on, the things that we can say movement-wise was bending forward. It seemed to give the patient some relief. He did like that. He does not like extension. Extension, not good at all. Even just having him face down when he does a prone cobra, he says that the pain becomes very sharp and that he can push through it. But again, his demeanor and his pain tolerance when dealing with this has always, strangely enough, been quite pleasant. But he says, I've been dealing with this since 2002. I can either sit here and cry all day and be a victim to it, or I can just, try to be optimistic and put on a happy face. So definitely someone that I was really interested in trying to dig deeper and see not only what the cause of all this pain is, but what we can potentially do to help him out, because he's seen numerous providers and he has had zero relief. So, David, if you have your file, do you have the information from the previous conversation that we did for the MRI report or even the X-ray report?
Let me pull that up. I think I've got that.
Okay, and if you don't, then we can just verbally talk about that briefly also, and then I can give the update, which is the interesting part that I'm really curious to talk about.
I've only got the latest one. I would have to dig into the.
No problem at all.
Okay.
More or less, we didn't see anything that looked abnormal at all. In fact, actually, David, perhaps you can bring up the updated, just the image. If you have the either the lateral or the A to P of the updated images that I took, I think that would be a good place to start, because that kind of sets us back to where we were previously.
Perfect. One moment.
Yeah, take your time on that. So after our conversation, the panel had made several recommendations, both in treatment therapy and in imaging. And so let's start with the imaging. So we went back and we got updated radiographs here, just x-rays. Here is the A to P of the lumbar spine. Again, I'll ask everybody to speak in a moment after I'm done here. But from my perspective, I didn't necessarily see anything, and the radiology report also did not suggest anything out of control, different, or worrisome from this perspective. Then, Dave, would you mind clicking the lateral x-ray, the image 2? Okay, so here's the lateral, and this is where the conversation is going to start. So one of the recommendations made by the panel was to get updated flexion extension exercises. Also, you all get a nice little chuckle about this. So we ordered flexion extension x-rays. These were taken last Thursday, so just a few days ago now. Would you mind going to x-ray 3 here, David? Thank you so much. Now, aside from the spine, the glaring obvious mistake on this one is it was labeled extension when, of course, this is indeed flexion. And then can you click the extension image? Okay, and then from there, David, and of course, once I send this back to the panel in just a moment here, I'm open to questions, conversation. Do you have the report from the radiologist from these two?
I do. One moment.
Yep. So while David's pulling that up, I'm going to go back to therapeutically what we have been doing for this patient, Jim, since which has been beneficial. So one, the patient has completely, and he said he was fine with just going just cold turkey, stop the ibuprofen. So we're at zero ibuprofen right now. He also has taken the past couple of weeks and he's really limited his activity to just the therapeutic exercises, which we've been working on. Now, when he comes on manually, I've been doing a lot of just kind of decompression. I've been doing a lot of just gentle axial distraction of his leg to try to decompress the lumbar spine, which he really likes a lot. That seems to be very beneficial. And in terms of motor control exercises, we've simply changed his direction. We're doing a lot of flexion type of exercises. So some of those include predominantly kind of the dying bug progression with posterior pelvic hip tilt, which immediately upon posterior pelvic hip tilt, he says it feels a lot better. He said it feels really good. He's been doing posterior pelvic hip tilt with arm raises. He's been doing standing posterior pelvic hip tilt against the door with arm raises. Same with like banded exercises. He also can do curl ups gently where he does posterior pelvic hip tilt, activates his abdominals, and he says that takes a lot of the pressure away. Now we can take a look at the radiology report whenever David has it. Okay. Now, previously I mentioned we had seen some x-rays, but they were static. We saw an A to P, we saw a lateral. We even had an MRI, which for the most part, you know, the radiology reports and the images didn't look over exciting, but this was the first big finding that we have seen for this patient. And once again, you know, thank you all for the suggestion, because this is huge. So once again, the impression, and I spoke with the radiologist. He said his report is in correct flexion extension. He said that was an error on the rad tech, but he said the way that he read this, he was correct, taking in flexion extension. So obviously I'll just read out the main impression, which is number one, dynamic instability at L3, L4 with 7 millimeters of anterolisthesis with flexion that decreases to 3 millimeters with extension, and at L4, L5 with a 4 millimeter of anterolisthesis with flexion that decreases to 2 millimeters with extension. Now, as I hand this back, I would like to say he really likes the therapy. He says it does help a lot, but he's still unfortunately having some days where he'll drive, he'll go to work, sit at work, and he feels like it just comes back. So what's everyone's thoughts on the update?
Can get our panel on video, please.
Dino, what does his, what does the quality of movement look like with flexion and extension? Do you see, is he able to maintain a sagittal plane with that? Does he have any frontal plane deviations? In other words, is there, there are clinical signs of instability as well? Particularly, pain again with the extension phase, on return to neutral from flexion, those kinds of things. Can you comment on that?
Yeah, no, so specifically in flexion, he's able to go down smooth. There's no deviation in any of the planes. It looks good. And in fact, he says when he bends straight forward and we started doing some repetitive movements, he likes that a lot. So he said, if I could stand and just kind of bounce and stretch my hamstrings all day, that would be great. Now, it's surprisingly similar with extension. He can go right back, Marcia, but he does not like that. So he's not really leaning to one side versus the other. He's not rotating at all. He can get straight back, but it's not good right away. And the same thing with exercise. We have completely taken out anything extension based, of course, from his exercises. And right now he's all more or less posterior pelvic hip tilt with some flexion. And those are the movements that he's getting a lot of relief from. But again, we're kind of pushing his therapy. We're pushing his sets and reps that he's doing at home, but he's still having these days where he's like, look, I want to be optimistic about this, but he's like, if I could do the exercises all day, I'd probably be pretty good. But when it goes to normal life, not so great.
Okay. One other quick question. What's his glute strength like? Does he drive that extension movement with his spinal extensors, or does he engage his glutes when
more spinal extensors? Yeah. Much more spinal extensors, definitely. Yeah, he's not really getting a whole lot of it. And in fact, when he does engage the glutes a little bit more with extension, that kind of even increases the pain a little bit.
Okay. Okay.
Yeah. And also, Ducks, I would be happy for, because I look at some x-rays, but I certainly don't feel like I'm a specialist at reading them. How could there be that much instability, but at least the radiologist did not say anything about any type of a pars fracture, or is this more of potentially just a ligamentous instability? What do you think structurally is going on with that?
Yeah, well, that's one of the things I was wondering about is the he's got significant anterior translation on flexion, which that's the basically the gold standard for identifying instability. But what I'm curious at is why he has instability. What is unstable here? He doesn't even have a spondy, I don't think. Did on the lateral, did he have a spondy at all?
No, it didn't say, at least the report, and not that I saw.
Yeah.
Again, I'm not an expert. Maybe you look at more x-rays than I do, but I didn't see that, and the report didn't reflect that either.
Yeah, and had he had a significant injury in the past? Severe car accident or something like that?
So here is what he is very confident. He says, Dino, I wouldn't call it trauma, but it's certainly a repetitive stress. He said, I think this was all linked to my teenage years, my 20s. I surfed a lot. So he said, I was in extension on the board, pushing up, paddling out. And he is convinced that that was the mechanism of injury. Now, once again, nothing traumatic, but I don't know if that's something that you could see over time with extreme repetitive stress that could cause something like this.
Yeah, and refresh my memory. Did he have an MRI?
He did have an MRI. I could pull that report up here if you give me just a moment, but the MRI didn't really reflect a whole lot. It mentioned some pretty standard minor disc issues. I think last time we got into a little bit of a discussion, there was like a small cyst somewhere that we were kind of saying, maybe. But it certainly didn't mention anything about the instability. It didn't say anything ligamentous, but I can pull that.
I've got it here, Dino.
Oh, excellent. And again, a lot of this information is very, very old, from 2007, 2012. But he says the pain hasn't changed since he started this whole journey.
Here's the MRI report.
Yeah.
This is just under 10 years ago.
Yeah. But if he had a significant ligamentous injury years and years ago, it probably wouldn't show up on the image. I'd be curious to look at the stir images, but if you look at the stir images, you may find high signal in the ligamentous structures. They probably wouldn't even comment on it. The radiologist might not even comment on that. So you may, that would be interesting to access. And if this was 10 years ago, who knows if they even did stir images, but I would want to look at the stir certainly. But either way, so it could be having had a significant ligamentous injury, but repetitive extension wouldn't cause that. Of course, repetitive extension in youth may cause a pars fracture.
Right.
And that could have become unstable. It's very uncommon for isthmus spondylolisthesis to become unstable, but that could have been the origin of that whole thing.
Right.
So his description of that may be what you were suspecting, that he may have had a pars fracture at that time, and it ended up becoming unstable. So it went from being a symptomatic spondy to a symptomatic instability. That may be the scenario we're seeing here. Did you notice, we talked last time about going over the three standard examination procedures for instability. Did you look at that? And if so, what did you find?
I did. So the test that you were referring to, Doc, those were the hip extension test, the prone instability, and pressure off the floor with the prone instability. Were those the three that you were referring to?
Well, I was talking about the ones that where you're looking for passive instability, basically, not impaired motor control, but rather the passive extension, passive lumbar extension, where you raise the legs up in the air.
I did not do
sill sign.
Yeah, no, I didn't specifically do that first one, Doc, but I can tell you he would not like that.
Yeah, I'm sure he wouldn't.
No, yeah.
Yeah, and it'd be interesting to see when he's standing or sitting to see if there's a ledge where one of the spinous processes are so prominent that it's like a ledge that is created. That's the low lying mill sign, sill sign.
Yeah.
So that's you might want to look at that. That would be interesting because that would kind of be a clinical correlation to the suspicion that this is symptomatic instability.
Sure. Okay. Yeah, I'll definitely take that a look at that. I think he's coming in either this evening or tomorrow. Like I mentioned, if I kind of lifted up his legs passively and he stayed still, that would certainly be positive. I know he wouldn't like that at all. I'll take a look at the sill sign. I can't remember that just upon him being prone or even standing, because I have observed and palpated the spinous processes. He said I haven't noticed that, but I'll take a closer look at that today when I see him.
Yeah. And then you had explored, I think, repetitive extension. And what did you find when he did that?
Not good. Just
Worsened.
bad, worse. Yeah, that was, he didn't like that at all. But the flexion repetitive, he likes that. He said, if I could just walk around at work and just, bend forward like this all day, things would be great.
Okay. But did repetitive flexion end up resulting in improvement over time? Or does it just feel good when he does it?
It's just temporary.
Okay.
Again, he was trying to, he took away the ibuprofen. He even took away his hiking, which he was pretty ambitious about. And he said, okay, I'm just going to do these exercises. He said, every day I can't wait to do my exercises. And he does them and he says, wow, I feel great. And then he says, I'm trying to be optimistic, but at some point the next day I'll be sitting at work and I'm just like, oh, it's back to where it's been this whole time. So at least since we've talked the last, he gets temporary improvement, but he would say, if I'm being honest overall, I don't know that this is resolving the problem.
Wow. Okay.
I was just going to comment too, that in addition to the tests that were just mentioned, I think the prone instability test might be even more informative because, here you're doing the P-day pressures without engagement of the spine extensors and hip extensors, and then seeing if there's a difference in pain level with P-day pressures when he engages those muscles. I almost hate to go down this route, but this is kind of the classic movement system impairment of extension syndrome, where he may be just overusing his long extensors, or the erector muscles, not engaging enough some of the intersegmental muscles, the multifidi and hip extensors, particularly. If he's not really engaging his hip extensors, and if he's a hiker, that would be particularly significant. And I hate to go down that route because it gets messy, but these are the things that would stand out to me, particularly that he has this pain, with repeated extension, and he just, he's getting this temporary relief, but it might be his motor pattern. But obviously, that falls more into the clinical instability, where he's got also, some mechanical instability as well, which makes it interesting. Yeah.
Yeah, and that prone instability test, we don't know, but it certainly stands to reason that would be positive in impaired motor control, but it would also be equally positive in a true instability. So it stands to reason to check that out and see it, because if he's consciously engaging the intrinsics, if that takes away the symptom or reduces it, number one, it's positive, so it's probably supports the diagnosis of instability, but also it may suggest that getting him on heavy duty motor control training may be what he needs to use muscular support to stabilize that unstable segment, to compensate for the fact that whatever ligamentous structures are not doing their job, to compensate for that. Yeah, I think that would be a really smart thing to do.
Okay. Yeah. So we'll recheck those dynamic instability tests, and I can kind of report back to you guys. Now, at what point, and Marcia, thank you, I'll certainly work on more like specific glute max engagement is what you're more or less referring to try to strengthen those the best we can. Now, at what point, if I continue this, would this be, or would this potentially be a surgical candidate, or is that kind of?
I mean, let's, we have a few other things to cover, but let's say that we come to the conclusion that, yeah, this instability, that's the problem. It becomes a shared decision-making thing, really, because the option is to do nothing is always there.
Yeah.
But it's it's his sense of, can you tolerate this? Can you live this way? If this were never to improve again, what would you think of that? And would you consider something invasive to do something about it? If that's the only thing that was left to do, would you consider that? Like the patient with progressive motor loss, you have to say you need the operation, you need surgery.
Right.
This is like, you don't have to have it. You could, the downside or the result of not doing it is going on like you are,
Right.
And so it's a lot of that is the shared decision making part of it, rather than insisting, oh, you really need to do this.
Of course. Yeah.
But what I wanted to know, oh, sorry.
Sorry, I was just going to say, we do have 2 other images and 1 video. Just so
Okay.
you're aware, I don't know if you want to bring those up at any point. Sorry, back to the conversation.
Yeah. Go ahead. Why don't you show those images, and you can just pull them up, whatever's there in front of you, David, and I can kind of talk a little bit about those. I wanted to send the video, but the video file was a little bit too large. Okay, so this is just a still shot of him pointing to exactly where the pain is when he does the movement he's about to do here, which I also found to be quite interesting. So you can go to the next image. Okay, so here he says this is, so he's standing on his left leg. He said that this did not cause pain, strangely enough. So he said when he stood on his left leg with his right knee bent roughly 90 degrees, he said, and this kind of made me shake my head a little bit, he said that this is no pain. And then the image after that, you can also show.
I've only got those 2.
Oh, okay. Yeah, so there was another image where he stood on his right leg, and standing on his right leg with his left leg bent, he said it would take the pain away completely. So I was really confused and scratching my head why single leg stance like this. Is it because of the muscular engagement that it's stabilizing that instability, and that's why he's feeling little to no pain? And then there's a third image which I didn't end up attaching, but it's simply him doing your traditional self traction where he's holding on the side of my table, bending his knees and letting it all decompress. And again, he said that completely ameliorated any of his pain and symptoms. So he's certainly able to get into positions that he's comfortable in. It's just, again, it's concerning to me that, with therapy and he's being compliant and he's staying away from, his hobbies right now, trying to be on this. And it's concerning to me that he still frequently will have a day where he's like, I just don't know if this is going to get better or not.
Has he used a rigid type lumbar brace at all? And seen what that did?
No, I don't believe so. Certainly if there.
Yeah, that might help make the decision about
Yes.
whether you want to get a surgical consult.
Okay.
If
Okay.
it
And is there
really ameliorates a lot of his problems,
okay.
Yeah, good
I
point.
think I'd go
Good
for the
point.
surgical consult.
Okay.
Dino, we the last time we talked, a lot of people were speculating on the possibility of instability, but there were a few other things that we and others had suggested you look into. Did you investigate those other things? And if so, what was the outcome of that?
Not quite so much, Don, because again, I sent him in for the flexion extension images just last week, only after, because I felt like the first couple of weeks we were really making a lot of progress. He liked the flexion. Man, this is helping. I'm not taking the ibuprofen. I'm continuing to improve. And then right around kind of early last week, he just had a few days where he's like, I don't know. He's like, I was at work today. I was just sitting there, and he said it just got real bad. So that was when I said, okay, well, I was real optimistic that these flexion exercises were helping to stabilize whatever was causing his issue. And that's where I said, okay, well, we need to get these flexion extension x-rays because now I'm not sure how much the therapy is helping. Got those, and I haven't really done anything aside from just an aggressive just motor control, primarily in that flexion position, which did seem to help. He still says it does help, but once again, it seems to be very temporary for him. And I just got those images back in last Friday, which obviously I was like, okay, well, this is good timing for this discussion, because this probably changes things a little bit.
So, so you had him on doing regular flexion, and he was doing well for a while, but then he had that one day that his pain was worse, or was that?
No, it's been several days. It's been several days. And again, I think him being optimistic was him saying, boy, these exercises feel great. I feel great after. Maybe now we're finally barking up the right tree. And now he's kind of like, you know what, if I'm not doing those exercises, it could come back, plain and simple. So.
Okay.
Did you want to show the video? Do you know?
Yeah, if there's a video that came through, I'm not sure.
Yeah, we did get it.
Sure which...
We did get it. So
go ahead and tell me what you just said there.
So when I get rid of that hump right there and
Yep.
push down on it,
So
it feels better.
Posterior pelvic hip tilt alleviates that
Downward.
pain. Yeah.
And if you pushed on my hips right here, it would feel the pain's gone.
And you said even like in your car, just kind of doing that, just pushing that arch out.
Yeah, because the car pushes my back this way. If I push my back that way,
then it goes
so
away.
Much better like that. There's the pain, and then like that, and it's
gone.
Yeah.
Okay.
There was a question about ibuprofen. Did stopping ibuprofen change his pain or activity tolerance?
No.
Allison?
No, not for the better or for the worse. He stopped the ibuprofen, and he kind of said, well, maybe I should have stopped that a while ago, because it's not really making much of a change. Now, also, he has cut his physical activity, so I have to mention that. He stopped the ibuprofen, but he's also stopped the hiking 2 miles a day, 8 miles on weekends, which is something he certainly wants to get back to. But getting back to what John had mentioned about the rigid back brace, I am curious about that, because that, again, before we talk about a surgical consult, might be something he would be interested in. Is there any specific type of rigid back brace that I should be looking into for Jim, or anything that you would recommend that I can make note of?
I mean, the as far as the type, a full TLSO would be the, make sure that it covers everything, so that you're completely stabilizing. If you really want to make sure to count on the finding of having it in there, you want to make sure that he's very fully stabilized. It's kind of costly.
Yeah, I know
orthotic,
that's
but
the downside. Just one of the elastic belts isn't gonna really give you an accurate representation, and
They have
I
to
don't know that
customize that.
Marcia would know better than I.
Oh, yeah, they have to customize it. It
And
it
that
is
would be
costly.
really
So
an
I think you
expensive
might,
test.
right, you might
Yeah,
want to
exactly.
whether his insurance covers something
Yeah,
like.
that's the
or-
problem.
Okay.
Yeah, but you're right, John. It's just a standard lumbar support. I mean, that leaves the lumbosacral junction relatively free. So I'm not sure if you can even count on what you found. If he says that, oh yeah, so much better with a standard lumbar corset, then that is useful. But if he says no, it doesn't help, you're not so sure. So that might be worth going that. Just getting a simple thing first. Go with that. If it's positive, then you're pretty confident. If it's negative, then maybe go a step further,
Sure. Okay.
So, yeah, but one thing about the Flex X is that the false negative rate is fairly high, because you don't know whether they fully flexed when they were doing it, but there's no false positive really. That if he's really translating that much, that there's no faking that.
Right.
So that's a pretty clear, obvious positive.
Right. Does anybody have anything to say about now, especially on the flexion? I mean, there's actually very little, obviously the translation with the intraosseous, but there's very little actual flexion of the lumbar spine. Is that indicative of him maybe splinting to try to protect himself in that? Because it really doesn't look like there's really much flex lumbar spine when he does do that flexion.
Yeah, I did notice that, but the fact that it's translating, If
Yeah.
it's translating, even if he is bracing, that's even better evidence of instability. Sorry, John, I didn't mean to.
Yeah,
Oh,
no,
Joe.
absolutely. I agree with what you said. I mean, the fact that there's 7 millimeters of translation is in and of itself sufficient. However, there is something called a modified Schober's test you could do where you make you make two marks 15 centimeters apart using like the PSIS as the 0 point and go 5 below, 10 centimeters above, then ask them to flex forward. And there are normative data established that if in a male, I think it's to show full lumbar flexion, it would increase by 6 or 7 centimeters. And that would show you that you're getting full lumbar excursion, and it isn't hip movement that's compensating for the lumbar spine. So you could actually, and it correlated very well with radiographic mensuration. So this simple modified Schober's test actually is an accurate way to determine how much lumbar flexion you're getting versus hip flexion.
There's a couple of questions and comments. One from Jeff, sure. Was a cyst confirmed as opposed to bone island or hemangioma? These could possibly explain his longstanding symptoms and prior response to care and exercise.
So we once again, unfortunately, we're still working on trying to get the physical images. He did put a request in, which they said was going to take 5 to 8 weeks. I told him to just drive there and just ask for the CD, but unfortunately, we don't have the old MRI image. But on the impressions and on the findings of the flexion extension views, they don't. Yeah, there's no mention to that cyst. There's no update on bone island hemangioma. The impressions are simply the dynamic instability, minimal apex left curvature of the lumbar spine, and mild disc space narrowing and fisted arthropathy L3, L4, L5, S1. That's really it on the X-ray.
Did I miss the cyst? Was there a cyst found?
Yeah, so Doc, in our previous conversation, we started kind of going down the road of like, well, it could be this cyst. So on the MRI report, which again, unfortunately, we are unable to see the images of, but on the MRI report from, I can't remember if it's 2007 or 2014, there was mention of a cyst, which I think, especially a lot of the participants were asking, hey, do you think that is noteworthy? And again, unfortunately, I don't have an update on that because I don't have the physical images. Hopefully I can get those at some point
Okay.
in the near future, but no, I don't have any updates on exactly what that cyst finding was.
Okay.
No, another comment in the chat. Let's see if I get to it. It is from Allison. She's just suggesting that this OTS Aspen back support, she's had some experience with that may be able to give more information than just a custom, TSO.
Yeah. Yeah, that's a good idea. Yep.
Okay. OTS Aspen back support. Is there a certain brand of it? Because I just pulled that up on here, and I just, especially Allison, if you have any specific recommendations on that. Again, I think at this point, our guy Jim wants to try everything he can, and hopefully not need to get the surgery. So if there's Aspen is the brand of OTS off the show. Okay, got it. Thank you.
Yeah, and I guess if he has, given Allison's experience, if he does have significant relief with that, and he wears that when he does his hiking and other things, and that's enough to keep him happy with his activity level, but not having to get an operation, that may be the answer here.
Absolutely. Yeah. Okay, great. Yeah. And again, he's completely open to continuing with because again, we want to do everything we can to try to avoid the surgical consult.
And you'd want to make sure you educate him on what to look out for in terms of if he's going to develop any motor deficits at that level between L3-4, here's what you want to watch for. And if you start to develop weakness, in these muscle groups, then you gotta make sure you call me immediately.
You mean because of wearing the brace? Is that what you're talking about, John?
No, I'm talking about just if you're gonna manage this conservatively with just a brace, he's got no, neurological deficits at all. So going for surgery seems like it might be a little extreme. However, if you're gonna just have him use a brace as a management technique and maybe follow up with you periodically, you've got to educate him about what to look for if it did progress to neurological deficit.
Yeah.
Yeah, and I've even preemptively taken some circumferential measurements of, his thigh and lower leg to make sure, even just visually when he comes in, we can keep an eye on that, make sure there's no, atrophy going on that maybe he's not even completely aware of.
Yeah, it's interesting about the surgical consult when it comes to instability is that, I mean, instability is relatively uncommon to begin with. And, I don't know, in a 30-something year career, I guess there's a handful that I've recommended surgery in somebody with instability, but most do well, without, with heavy duty motor control training. But, when it comes to, if you have to consider it, really, true instability is the only evidence that is the indication for fusion. That's the only documented benefit of doing fusion. Fusion is a controversial procedure, but it's not that controversial when it comes to instability in the person who fails an adequate trial of non-surgical management. So it's so uncommon that any of us would send that, because it's an uncommon condition, usually does well, and we're used to referring people with progressive motor loss because that's a little more common. But really, again, it's a reasonable option if you really exhaust aggressive non-surgical management.
Yeah. So no, I mean, all that makes sense. And again, these are all things that I think he's open to trying, and not to be pessimistic, because I'm not being pessimistic about this, but if we were to go down that route, is there a certain type of doctor that you guys would prefer to take a look at him to do this type of consult? Do you have any recommendations, or, what would I look for? Because if the worst case scenario were to come and we're just like, you know what, I'm sick of this, I'm willing to get the surgery, I just need to fix this, and the rehab is not seeming to make things better, is there anything in a doctor that I should be looking for to try to make a good referral to help this patient?
A reluctant surgeon.
Yeah.
Yes.
Yeah, one you can count on to be conservative. Certainly, yeah, that would be. But in general, somebody who's a spine surgeon, so a neurosurgeon or a orthopedic spine surgeon who has a fellowship in spine, certainly you only want to consider somebody that's all they do is spine, which that's not too hard to find. But whether it's neurosurgery or orthopedic surgery, as long as it's an orthopedic surgeon who has is fellowship trained in spine, in those two groups, there's not a big difference. But
Okay,
obviously, do homework and find out somebody who's got stellar reputation and all that kind of stuff. That's a bigger deal.
Okay, thank you.
A really interesting case.
We do have a comment from Kim Miller. What position does he sleep in? There is a lateral flexion restriction, L3 question mark, therefore a lateral disc short leg.
Okay, let me take a look at that, because he did say a comment in the email here about his sleep position. Let's see. Okay. Okay, what caused the pain? Sleeping on my left side makes it worse. Sleeping on my right side with a pillow between my legs lets me sleep. So left side, not good. Right side with a pillow between the knees is helpful. Lying flat on my back makes it worse unless my knees are up, which again makes sense with the posterior pelvic hip tilt. Bending forward stretches of the muscles. Yeah, so that's what he has to say about sleep.
Interesting.
Good question. Yeah. Specifically, as Marcia has mentioned, specific to hip extension, glute activation, we have potential bracing, and yeah, Sounds like a plan.
Yeah, I think I would want to again make sure he's recruiting the transverse abdominis and multifidus. You know, the deepest layer. That's typically the those are the muscles that become inhibited in people with chronic back pain anyway. But also, like Marcia was saying, somebody with instability, you know, you want to make sure he's recruiting those muscles with any activity. So I would really want to heavy duty focus on those and train the hell out of the multifidus. You know, in addition to everything else.
Yeah, I was going to say too, with the bracing, it's not, you know, either or. It should be, you know, that would be the time if he's getting some relief with the bracing, you know, really work on the motor control, you know, and see if you can then wean him from the brace at some point. Maybe
Yes.
not. Something else I was going to, oh, and it's interesting, you know, maybe his, you know, his hiking, you know, it's just some general movement. If he stops his movement and he stopped his ibuprofen, that can certainly change the balance of pain. And so, you know, if he can find an activity that, you know, allows him to just continue to move his body, because there is a certain pain biasing just with movement, period. You know, and again, he was on ibuprofen for a very long time and he came off of it. It's just kind of interesting that, you know, he didn't get some kind of rebound just from that.
Yeah. Yeah. That is interesting.
Looks like Dino's video might have frozen, but while we're waiting, Alison Hackett said, maybe an orthotist can give you suggestions about bracing.
Yeah. Good idea.
While we wait for Dino to connect back up again, let me use this opportunity to encourage any of you who are on this webinar and not members of the Primary Spine Provider Network to head on over to primaryspineprovider.com and sign up for a monthly membership, which gives you access to be a panelist and to present a case like this and to have our team dissect it with the level of precision that they have thus far. So we would encourage you to do that. Click the link in the chat and spend $7 a month, which is barely more than a coffee. And we do donate $1 per month per member to World Spine Care to help deliver spine care services to underserved communities across the world. So with that, we kind of are at the just about the top of the hour. We normally do spill over a little bit for further questions, but I think we have pretty well exhausted this case and made good progress. Really huge thanks to Dino for his careful preparation and all of you for your contributions, and Don, Marcia, and John for your insightful questions and guidance. Anything else you wanted to add?
Good case.
Good stuff. And for those of you that are on the call, if you're members or not, feel free to just send your case in. We would encourage you to join the membership. Send your cases in, email them to us. You can email admin@spinecarepartners.com, which I'm putting in the chat, or communicate with us on the website. We look forward to future cases. Watch your emails for future events from the Primary Spine Provider Network.